Hello everyone, my name is Kong Shrinani and welcome to my YouTube channel NeuroChat with AG. On this channel, I plan to cover topics that are closest to my heart and support the neurodiverse community. Topics related to neurodiversity, autism, late autism diagnosis, and autism in women and girls. I will interview thought leaders, esteemed researchers, scientists, professors, doctors, and psychologists and seek their views and updates on their latest work and research. I will also chat with parents of neurodiverse kids and adults and talk about experiences of neurodiverse individuals. Lastly, keeping inclusivity as a topmost priority, we might also discuss controversial disparate views for a collective understanding of issues and respect for diverse views. All the views and topics discussed are for informational purposes only. If you are interested in watching more quality content on this topic, please hit the subscribe button. Don't forget to press the bell icon to be notified whenever a new video is uploaded. Please also share the channel with your friends, family, and social media platforms. Thank you. Today, I have the privilege of speaking with Dr. Geraldine Dawson, a highly influential figure in autism research and clinical practice. She is the William Cleland Distinguished Professor at Duke University's Department of Psychiatry and Behavioral Sciences and the founding director of the Duke Center for Autism and Brain Development. Renowned for her transformative contributions to autism research, Dr. Dawson has explored the neurobiology of autism, focusing on early detection, biomarkers, and the development of innovative interventions. Her extensive study emphasizes early diagnosis and personalized therapies, hoping to enhance the quality of life for individuals on the spectrum. She's well known for her help in developing the Early Start Denver model, an evidence-based early intervention approach for autism, which I'm sure we'll hear more about. So, Dr. Dawson, welcome and thank you very much for the time today.
Thank you for having me.
And to jump right into it, could you please talk about your journey and how you got involved in the field of autism?
Sure, I'd love to. So, my journey began when I was probably about your age. I was in high school, and we had a family that lived across the street who had two children on the spectrum. So, these were twin boys, about 6 years of age, and their father had a serious kidney disease and needed to have dialysis. And in those days, you had to travel long distances to seek help. And so, as the father was seeking that kind of help on the weekend, I would go over and take care of the kids. And it was a great family. Also, with the grandfather was there and an older sibling as well. And through that experience, I got to know these two young boys. Neither of them, spoken words, and they had their own special interests. I remember when I would set the table, they would want the table set in a very specific way. They loved to play pool with me. We had a pool table at our house, so they would come over and play pool with me. But through that special relationship, I learned about autism firsthand. I felt very curious as a person who's always been interested in human behavior and how the brain works. What was different about these boys that made it so that they couldn't speak, but they could do so many other amazing things. And I also enjoyed them immensely. And I decided, as a person who eventually studied brain development and child development, that autism would be the area that I would focus on. But that was my first exposure, and I really never looked back. I was very intrigued, but also inspired by my first relationship with those autistic boys.
You speak a lot about changing or reshaping the narrative about autism by applying asset framing. So, could you please explain what it is and how it works?
Yes, the concept of asset framing is that as we talk about different topics, we create a narrative, we create a story. And as we listen to information, our brains are constantly forming images and understanding and biases about whatever's being talked about. And so, if we begin a story or a description with a negative descriptor, the brain then tends to funnel information towards that negative perception and ultimately will bias how we think about, people or situations. And so the concept of asset framing is that when we describe a situation, in this case, autism, what if we start out with a positive frame? So if you think about even when you provide diagnostic feedback to a parent about their child, if you start out by describing some of the challenges that are associated with autism, that parent is immediately going to be thinking of their child from the point of view of deficits, what the child cannot do, the problems the child has, the challenges the child's going to face. Whereas if you start out with talking about the very special things that their child can do, things that perhaps you and I can't do, whether it's, being able to remember things, visual processing, sometimes musical abilities, many other capabilities. And you describe those first, and you frame them as differences and not deficits, you can completely reshape how people think about autism. And so not only a parent could leave that meeting with more of a sense of hope and also respect for their child, um, but also it could affect that child's trajectory in terms of how teachers treat them and others in society. So that's the concept of asset framing. I think it's really important.
And your book, An Early Start for Your Child with Autism, discusses the Early Start Denver model. So please tell us some more about that.
Yeah, I'm happy to. So the Early Start Denver model is part of a larger group of early interventions that are called naturalistic developmental behavioral interventions. So let me just unpack that, each one of those words. So naturalistic means that when we're working with a child, developing a relationship, helping that child to develop language skills, communication and learning skills, social skills, that we're doing so in a way that very much is like how we would naturally interact with anyone. This is very different than, say, a traditional applied behavior analysis or ABA type of format in doing early intervention, where you might sit down, have someone sitting at a table and going through drills. Rather, the goal is to be able to facilitate the development of social skills and language skills through interacting in a very natural, play-based manner. And this is very much, of course, how neurotypical children learn about social skills. So we don't sit a neurotypical child down and say, look at me, this is how my face looks, when I'm angry and so forth. But rather, that child is able to pick up on that information through natural interactions with other people. So now, of course, for a child on the spectrum, they don't easily pick up those skills. So you're structuring that interaction in a way that accommodates their particular way of learning. So the interaction is probably highly structured. It's also more predictable. You're being very sensitive to the way in which the child best processes information. Some children may be more visual processors, others more auditory processors. You're also trying to develop routines that the child will understand and then adding variation. You're sensitive to things like, is the interaction overstimulating? So you can tone down the interaction or if the child appears to be overstimulated. But so you're still trying to keep the interaction as naturalistic as possible. And that's important because if you learn skills in that naturalistic way, you're much more likely to generalize those skills to the natural environment, which is, of course, what you want. Developmental, the second piece of a naturalistic developmental behavioral intervention, or NDBI, is the idea that we learn skills in sequence. And in neurotypical development, there's a well-known sequence of skills that are acquired that then lead to later skills. So, for example, if one is going to be learning language, you want to start with very early skills of things like being able to use gesture, being able to notice certain nonverbal cues, and these really then provide a foundation for language. So when we look at the Early Start Denver model, there's a very detailed curriculum in terms of the sequence of skills that are developed. And that sequence is based on developmental science, years, really decades of research on the sequence in which skills are acquired. And that then facilitates and helps children to acquire those skills. The behavioral part of it is that we do incorporate some of the basic teaching modalities that come from applied behavior analysis. So things like reinforcement and shaping, much again more play-based. It's also much more child-directed. So it's very important that the child is highly motivated to be part of the intervention, that they enjoy it, that you're using child-preferred activities and that you're following the child's lead in terms of their particular preferences. And when you do that, you find a child who's actually excited about, coming into therapy and learning these skills. It doesn't feel like being drilled. It actually feels like playing and learning through play.
And your other book, A Parent's Guide to High Functioning Autism Spectrum Disorder, discusses how to meet the challenges and help your child thrive. So, how can parents and educators ensure they support these practices at home or in school?
Yeah, so well, just looking at that title, we're actually in the process of revising that book because it's a good book. I think there's a lot of useful information, but it is somewhat dated and needs to be revised, and we're really excited about coming out with a new edition. So we actually don't use the term high functioning and low functioning, and or it's not preferred to use those terms. We use terms such as high support needs, low support needs, and I often don't use the term autism spectrum disorder, but rather just use autistic or autism. And that is reflecting a move away from a strictly medical model of autism to much more of an identity-based model. But with that being said, individuals with what we would think of as lower support needs, and in this case, what we're talking about is individuals on the spectrum who do not have intellectual disability and do not have trouble acquiring language, but still are challenged by navigating the social world. What are some of the strategies that people can use to make sure that those individuals are doing well? So it turns out that even a person who may be intellectually gifted and have no trouble in terms of language acquisition, as they grow into an adolescent and adulthood, those individuals still have tremendous difficulty in gaining a job and being able to navigate college, being able to develop friendships. And we've learned a lot about how to help people on the spectrum to succeed and to use all the amazing gifts that come along with being autistic. But at the same time, addressing some of the challenges so that people can be really successful. So that book is a book for parents who are raising a child that may not have intellectual disability or language difficulties, but nevertheless is having some challenges, particularly in navigating the social world.
Do you also talk a little bit about your work around a meta-analysis of treatments that found increasing intervention is not associated with greater improvement in development for young children with autism?
Yeah, so well, that wasn't my work per se. That I think you're referring to an article that was published and headed up by a person whose last name is Sandbanks. And that was a meta-analysis where the question is, would you expect better outcomes if you provide more hours of early intervention? And our common sense might say, yes, the more the better. And in fact, if we think back on the history of early intervention research, one of the very first studies was conducted by Ivar Lovaas, published, I think, in 1987. And in that study, they were providing as many as 40 hours of intervention a week, which, if you think about how many hours that is, that's just a huge number. What that means is that that young child is, really not doing much else during the week of the workday, so to speak, except for getting intervention. And so that was an old model, and there was a point in history where parents were being told that they really needed that number of hours for their child to have the best outcome. And there was a lot of problems with that. One is that it was honestly not very feasible on so many levels. How many therapists do you need to provide that many intervention hours? And also, what would the child's life be like? Like, when are they going to go to the park? When are they going to have fun? When are they going to take a nap? I mean, these kids are 2 and 3 years old. And also the cost, was tremendous if you're paying somebody and you're having to pay a specialist, that many hours to work with your child. But parents, nevertheless, were highly motivated to get this number of hours because they thought this was so important. So then, as we started to really do research and to do studies where we could look at the correlation between the number of hours of intervention you receive and the outcomes of kids, we were surprised to find that, we weren't seeing that 40 hours a week is necessary. So we conducted one study where kids were randomized into 4 groups. And across these 4 groups, we varied the number of hours of early intervention they received. This was for 1 year. And then we also varied the type of intervention they received. So some kids received the naturalistic developmental behavioral intervention, in other words, the Early Start Denver model, which is the model that my colleague Sally Rogers and I developed. And of course, we feel very passionate and think that's a great model. And then the other kids received traditional applied behavior analysis. So you were either getting high or low number of hours, and you were getting either naturalistic intervention, which is early start dimmer model, or traditional ABA. And guess what? All kids had the same outcome. All kids improved. But there really wasn't a significant difference between, in this case, 15 and 20 versus 25 hours, or receiving Early Start Denver model versus a traditional ABA program. And what that told us was that it's not a matter of just more is better. And also, as long as people are highly trained in what they do and they're really getting good supervision, and that the model has an empirical support for it, that kids are going to do well. Now, parents, of course, still may have a preference for one model versus the other, but honestly, we don't have a lot of evidence, as long as it's done well, that one model works better than the other. And that's good because often parents don't have a choice. They, have access to one or the other. And I'm sure it's very reassuring to find out that both work well. And then also, parents, I think, should be relieved to know that at least we know 15 hours, is just as good as 25. Now, you might say, well, why is that the case? I mean, obviously, there's a baseline because, or a baseline threshold, shall we say, because you have to get a certain number of hours, but maybe 15 is enough. And part of the reason why we think this is important is first of all, most people now believe that intervention needs to be very individualized. So some children may do well with only 10 hours a week, and you can monitor this by their rate of progress, whereas other children may need 25 hours a week to make the same kind of progress. So it really does need to be tailored to the individual child and the individual family. And then another factor is that when parents are participating in these early intervention programs, they themselves are learning these strategies. And in fact, any good early intervention program is going to incorporate parent training into their model. And what this means is that when kids go home, they're going to be exposed to these different strategies for helping the child to learn to speak and to play and to socialize. They're going to be exposed to these strategies at home for many hours a week. And so it's very hard to track really the number of hours that a child is receiving. But what we do know, and the key points here is one, high quality intervention. That means an intervention that has empirical support. It's been studied in randomized clinical trials, and it's been shown to be effective. Second, that you have highly trained and supervised people delivering the intervention. Third, that you're trusting that the parent and the family know what's best for their child and customizing it to the family and the child in terms of the number of hours. There's priorities in terms of the things that the parents might want to emphasize. There's cultural issues that need to be addressed. And then finally, really individualizing it to the child based on their rate of progress, and then changing constantly if the child is not making progress. So it's a very dynamic process.
Last question for you for today. So in this book, what science tells us about autism spectrum disorder and making the right choices for your child? And I know, like you said, this book was published, it's been years now, so like the language keeps changing, but you talked about genetic testing. So if there's an autistic child in the family, like what are your findings about genetics?
Yeah, so I'm going to broaden that question just a little bit, and it will incorporate genetics. But the point I want to make, as my last question, as you say, is that autism is not simply a behavioral health condition. It is also a medical condition. And autism is often associated with medical issues that need to be addressed and can have a huge impact on the child. And often these are missed. And a lot of times when children are brought in to see a doctor and they're presenting with some behavioral issues, the doctor is not necessarily considering that there's medical issues that need to be addressed. So I just like to briefly talk about those. The first is genetic testing. So we know about 20% of individuals on the autistic spectrum do have an identifiable genetic mutation that likely is the cause of their autism and also has important medical consequences. Sometimes when you identify a genetic mutation, it will allow you to understand what other kinds of medical problems that child may have. So, for example, certain kinds of genetic mutations are associated with a high prevalence of seizures. And you'd want to be very careful about monitoring that and providing treatment for it. But again, knowing if your child has a very specific genetic mutation can guide you in terms of the kinds of medical conditions that you'll want to be um, aware of. And also, there's medical treatments that are being developed that are targeted at specific kinds of genetic conditions. So that would link you to keeping abreast of what those medical treatments might be. But broadly speaking, even for individuals where you can't point to a specific genetic mutation, what we know is that autism is associated with a higher prevalence of sleep problems. So this is trouble falling asleep, wakening, and not being able to fall back asleep. And we know that there are certain genes that are responsible for regulating our circadian rhythm that are found more frequently in autism. Now, when a child is not getting sleep, first of all, it's very hard on the family, but it also means that this child is not going to be able to learn effectively, and you're going to see more behavioral challenges, more attention problems, more problems retaining information. So, addressing sleep is really important, and we talk about that in the book. The second is to pay attention to issues related to eating and the GI system. So we also know autism is associated with higher prevalence of GI problems. And in fact, we recently published a study that showed that these GI problems show up as early as 3 months of age, that these kids are already seeing a GI doctor more frequently, even before they know that the child is later going to be diagnosed with autism. And again, GI problems, are associated with pain and irritability, trouble sleeping, and so forth. And also eating issues. So picky eating and trouble with swallowing. These are pretty common issues that we know can be addressed through treatment. And then we also know that autism is associated with a higher prevalence of seizures. And so being aware of that and making sure that we're treating those seizures, because if they're left untreated, this can influence how the brain develops and can cause, later problems. So when we think about autism and you go in to see the pediatrician, it's important to think beyond behavior and to think about a holistic approach. And this does mean that treatment isn't involves an interdisciplinary team. So not just a psychologist like myself, but also, a physician, sometimes a neurologist, sometimes psychiatrist, an occupational therapist, physical therapist, speech therapist. So a lot of different people who can bring their special expertise to make sure that we're helping each individual become, reach their full potential.
Dr. Dawson, thank you for taking the time to speak with me. I'm really grateful for this opportunity to learn from your expertise and the groundbreaking work you've done in autism research. Thank you for your generosity in sharing your knowledge and experiences, and I look forward to seeing the continued impact of your work.
Thank you so much for inviting me and for this wonderful series that you're creating.